Hello, my name is Dr. David Horn-Solomon, and I'm the Chief Executive Officer of Pharnext, a Paris-listed biotechnology company. I'm very pleased today to be able to tell you about our advances with our lead compound, PXT3003, in Charcot-Marie-Tooth type 1A disease. And I will take you through our presentation today and give you details about our advances. As we're a publicly traded company, this is our Fair Harbor statement. And now, first I'll give you a snapshot of our company. We are a late clinical stage biopharmaceutical company focused on using innovative pleiotherapy platform technology to advance diseases with high unmet need, including our lead medicine, PXT3003, which is in phase 3 for the treatment of Charcot-Marie-Tooth type 1A. This is our pipeline, and you can see that our lead compound, PXT3003, for the treatment of Charcot-Marie-Tooth 1A is in phase 3 development. We have global rights for this medicine, excluding in China, which are held by our partner Tasly. We are now conducting our second pivotal phase 3 study called the Premier trial, and we've enrolled our first patients as of March 31st, 2021. We also have in the pipeline a medicine for the treatment of both Alzheimer's disease and amyotrophic lateral sclerosis, or Lou Gehrig's disease, but we'll not be talking about this asset in today's presentation. Our medicines are derived from our pleiotherapy platform, and essentially this is a platform that was advanced by the founders of our company to look at a disease network on one hand and to integrate knowledge from this disease network that comes from understanding all the genes and pathways involved in that disease, and then repositioning existing medicines using genomic data, and then ultimately doing classical in vitro screening, in vivo testing to advance medicines into the clinic towards an approval. And in fact, this is exactly what we have done for 3003, which I'll tell you more about. The company, Pharnext, has now built a strong foundation for value creation. We have an extremely experienced management team with strong industry and financial expertise, and also regulatory, manufacturing, and commercial expertise. We have an impactful board of directors with deep experience in clinical development, neuroscience, and corporate strategy, and we've received clear FDA guidance on the regulatory pathway towards approval for our medicine, PXT3003. So far, we have encouraging efficacy and safety profile for 3003 in Charcot-Marie-Tooth based on our phase 2 data, our first phase 3 study, and very importantly, extension study data that I'll tell you more about. Let me first tell you more about 3003 as a candidate treatment for Charcot-Marie-Tooth type 1A. I want to tell you how we discovered this medicine, the mechanism of action, and our earlier preclinical data. So as I mentioned in terms of our platform discovery, we essentially derived a disease network for CMT1A on the left side of this slide. And you can see all the genes and pathways involved in this disease network for Charcot-Marie-Tooth type 1A. And against that, we did virtual screening in silico of over 2,000 plus drugs. And from that, we selected 72 drugs to further screen, and we put it into an assay in Schwann cells where we could look at downregulation of a gene and a protein called PMP22. As many of you know, PMP22 is the defective gene in Charcot-Marie-Tooth type 1A, and patients that have Charcot-Marie-Tooth type 1A, in fact, all have a duplication of the PMP22 gene. So showing that you can in fact downregulate PMP22 is a hallmark of what we want to achieve to treat this disorder. And from that initial screen, 16 drugs were positive, and we then combined them in a variety of different manners and different ratios to ultimately come up with a combination that we now call 3003 that is a fixed dose combination of naltrexone, baclofen, and sorbitol. And from this discovery, we then went on in a variety of animal models to actually make sure that the mechanism of action was following what we believed was our discovery platform mechanism, and also the best way to use this medicine in patients. And so we used ultimately the rat PMP22 duplication model, a model founded at the Max Planck Institute by one of our collaborators, Dr. Michael Sereda, and some of the results are seen here. You can see on the top left of the slide what we all know, which is that in terms of axonal transmission from a neuron towards a motor end plate, the myelin sheath, which is affected, of course, in this disease, is normal. But in CMT1A, you can see the disruption of the myelin sheath owing the duplication of PMP22. We showed on the bottom left successful downregulation of PMP22 in these CMT1A rats. On the bottom right side, you can see cross-sectional views of nerve fibers where you can see the effects of PMP22 in either wild-type animals or diseased animals from this model. In the photomicrograph on the left side, you can see the very large, round axonal fibers, and they're all very heavily myelinated in that dark shaded area. You can see in the middle panel, CMT1A animals from the disease model have very small axonal fibers, and many of them are very poorly or unmyelinated and don't have that dark myelin sheath on the outside ring. On the other hand, with as little as 12 weeks of treatment with PXT3003, you can see that the diameter already of the axonal fibers is increased, and many more of the fibers have good myelin sheath, as seen by the dark rings in the staining of the slide on the right side. So these are key data that come from our disease animal model work. On the left side of the slide, you can see a study looking at myelination in the CMT1A neurons of this animal model. And you can see that when you look at treating with placebo in red on the far left side, you see no increase of myelination, nor do you see it when you use the individual components of our medicine, baclofen, naltrexone, and sorbitol. And when you use, in fact, dual combinations, baclofen and naltrexone, baclofen and sorbitol and naltrexone, you also see no increased signal in terms of myelination. However, I think most important is when you use the durable medicine, the triple combination that is PXT3003, you could see an appreciable and statistical increase in myelination. We also wanted to begin to study what happens in a more functional model in this rat durable model. And here we're looking at grip strength, where the animals actually grip a rod. And you can see in the left side in placebo, the grip strength in red. The double combinations, baclofen and naltrexone, baclofen and sorbitol, and naltrexone and sorbitol have no appreciable increase over placebo. But in green, again, you can see that the triple combination, the animals have a much increased grip strength, suggesting that, in fact, there is a functional benefit to the triple combination medicine that we call 3003 in this disease model. So I want to tell you now about our available clinical data from our earlier phase 2 study and our first phase 3 clinical studies. So this, in fact, is what many of you know about, which is the ONLS grading scale that is used, in fact, to measure functional motor disability. And on the left side of the slide are the measures in the arm, on the right side in the leg. And obviously, as you increase the score, the level of disability in terms of activities of daily living is increased, and therefore the disability is greater. And so we use this as a primary endpoint in many of our studies, and this is just a reminder of what the ONLS scale in fact looks like. And as many of you may know and experience, in fact, the decline as measured by ONLS, unfortunately, seems to be unstoppable and rather linear in the years since diagnosis with Charcot-Marie-Tooth 1A. So for example, 0 represents no disability, and a 12 would represent, unfortunately, in a wheelchair. And you can see that over the approximate 40 years from diagnosis, you can see the expected and unfortunately unstoppable decline in this disease. So we conducted at Pharnext a first exploratory phase 2 study where we wanted in patients to analyze and learn more about PXT3003 in the treatment of Charcot-Marie-Tooth type 1A. In fact, we enrolled 80 patients and randomized them to 4 groups: placebo, low dose, medium dose, and high dose, as you see on the left side of the slide. And on the right side of the panel on the graph, you can see over the 12 months of study period what happened with the medium and high dose when you look at ONLS. And in fact, the ONLS either stabilized with the medium dose or there was a slight improvement in ONLS over the study period, whereas the low dose medicine and the placebo had the archetypal decline that unfortunately we normally see in patients with Charcot-Marie-Tooth 1A. And I want to give you sort of a little bit of a backgrounder on what's meaningful in this disease. As you all probably know, in red is the average expected decline, and this comes from the large cohort of data gathered by Dr. Mike Shy at the University of Iowa. And you can see the decline in ONLS over time. In green, you can see our average expected improvement based on the early exploratory data we got from our phase 2 study. However, this is over 20 years, and you can see on the left side of the slide that when we measure over a year or 15 months, the difference between the expected improvement and the anticipated expected decline is rather small. But this is not uncommon in studying medicines for rare neurologic disease, where in fact the difference between what you study and what is expected in a short period of time is rather small, but still leads to approved medicines. So this is a review of our design of our first double-blind phase 3 study, and also what we've done in a continuous manner in our open label extension studies that continue to this day. On the left side of the slide, you can see the 15 months of study so far in our phase 3 program, where we have patients randomized to low dose, high dose, and placebo. And then all the patients were unblinded and were put on essentially low dose if they were on the low dose, high dose if they were on the high dose, and placebo patients were randomized either to low dose or high dose and followed for 9 months initially, and more recently an additional 30 months where all the patients were placed on just high dose medicine. So now we follow about 133 patients that continue just on the high dose medicine. So we have about 4.5 years of data so far, and every year we'll continue to read out another year of data from these patients. This is our earlier phase 3 study, and again on the left side of the slide we randomized 323 patients here to 3 arms: placebo, low dose, and high dose. And in fact the low dose was the high dose from the earlier exploratory phase 2 study, and now the high dose that we study here is in fact twice the dose of the earlier high dose, now called the low dose. The primary endpoint in this study is ONLS, and we measured a range of secondary endpoints, including the 10-meter walk test that I'll tell you more about. These are the results from our first phase 3 study, and you can see on the left side of the slide our results in ONLS. The high-dose medicine had an improvement over the 12 or 15 months of the study, whereas the low-dose medicine had a stabilization of ONLS, which we all know itself is clinically significant and relevant. And in red is the placebo-treated patients that have this unfortunate decline of ONLS over the study period. As I mentioned, we also studied the 10-meter walk test in these patients, and you can see a dose-related increase of the time, decrease of the time it takes to walk 10 meters. You see significance in terms of the high dose, a slight increase in the low dose, and a modest increase in the placebo, but we know this is a training effect of the 10-meter walk test. So again, a dose-dependent curve that shows the benefit of the medicine. We measured a range of other secondary endpoints, and I won't go into all of them, but you can see that there was a trending towards positivity, if you will, statistically, when patients were treated with the high-dose medicine as opposed to with placebo. We also carried out a responder analysis, and this is very important because we're able to show, in fact, that when we look at the odds ratio, a statistical measure of being a responder to the medicine in green, there was about a 3.4-fold increase of responding to the high-dose medicine compared to patients in red only receiving the placebo. So you see a real medicine effect, a real benefit of the medicine as measured by ONLS. It's important also to remind us all of where we're continuing to go with our treatment of patients with CMT1A with 3003. And these are the sustained benefits in these cohorts of patients, about 133 patients now in open label with the high-dose medicine. So let me run through this slide in some detail because it's fairly complicated. On the bottom of the slide, you can see the scale. On the right side is improvement in terms of ONLS. On the left side is worsening. And from the bottom up, you can see in blue placebo-treated patients, as you know, just worsened over the study period up to 4.5 years with placebo. But when they were switched to the high-dose medicine, you can see in orange on the right side, they began to turn around towards an improvement, a modest improvement of ONLS. The low-dose patients had a modest improvement, as we know, or a stabilization in the blinded portion of the study in blue, and when on the open label portion of the study with high dose, now they continue to accelerate and improve in terms of ONLS. And then finally, the patients at the top in high dose in the blinded randomized study in blue improved significantly, as we know, in terms of ONLS. And when continued now in open label format with the high dose medicine, they just continue to improve significantly now for up to 4.5 years. So we see a real medicine effect. We see that the effect is dose dependent. And we also consider this to be like looking in the crystal ball towards our ongoing now pivotal phase 3 study called Premiere, as we continue to see improvements on the high dose medicine in terms of ONLS. I also want to tell you about the safety profile for 3003. And now, after 4.5 years of total trial time, from the both double-blinded portion and also the long-term safety, the adverse events were mild to moderate and really compared to placebo over the 15-month period of the double-blinded phase 3 study. In terms of the extension study, again, a very good safety profile, and no safety signals have been identified over the period of this additional 39 months of treatment. Now I want to tell you more about our ongoing pivotal phase 3 study called the Premiere study. So in the same format as I've shared with you before, on the left side of the slide is how we're enrolling, designing patients for this study. The intention is to treat 350 patients randomized in only 2 arms. Now, again, with the guidance of the FDA, only placebo versus high dose. In the Premiere trial, we'll be studying patients for 15 months instead of 12 months. And this study is a pivotal international randomized double-blind placebo-controlled phase 3 study, again with the blessing of the FDA. The study is being conducted in the US, Canada, France, Germany, Spain, Italy, Belgium, the Netherlands, Denmark, and Israel. And the first patient was in March of 2021. The estimated enrollment period is about 12 months. And to date, as I speak with you today, our enrollment is going extremely well and is on target. So we look forward at the right time to share with you our results of this study, and we have disclosed and anticipate top-line results in September of 2023. The formulation of our medicine for the Premiere trial and for commercial launch will be in stick packs, and you can see at the very bottom of the slide that what we're using now is individualized doses of the medicine. The medicine, as you all know, is in liquid formulation. It has a banana flavor, whether you're taking the high-dose medicine or the placebo. And for all patients, they'll be essentially cutting open with scissors these small liquid sachets and in fact, drinking the liquid twice a day as the form factor. So I want to tell you our milestones and our anticipated path forward. To date, with 3003, in terms of our summary of our prior results, as I've mentioned, we've had positive phase 2 study results. We've had a very positive preclinical factorial study in the validated disease animal model at the Max Planck Institute with Professor Michael Sereda. We've had very promising phase 3 study results, as I've shown to you. As you may know, we've had a manufacturing issue with this earlier study, and that's why we are in fact carrying out a new and pivotal study called the Premiere trial. We also had positive phase 3 extension study results that I've showed you with patients treated for up to 4.5 years. And early in 2022, we'll be telling you about the results with up to 5.5 years of data in patients receiving the high-dose medicine. Most importantly, we've received a clear and written FDA guidance on our regulatory pathway towards approval, and we're following that to a T as an important way to submit our dossier, but also get approval for our medicine. So we're now in the middle of executing both a pivotal phase 3 study, the Premiere study, and also GLP factorial studies at the Max Planck Institute. And this will be the discussion of further disclosures from FarNext and further discussions with all of you. So I want to run through our corporate milestones that take us through 2023. And this timeline you can see begins in 2019 all the way through 2023. At A, we received in early 2019 Fast Track designation for our medicine. In January of 2020, we announced the top-line results of our first extension study of the long-term safety and efficacy of 3003. In March of 2021 at Sea, we enrolled the first patient in our premier trial, our pivotal phase 3 study in CMT1A. In April, we announced further results from our long-term extension study, top-line results that showed ongoing safety and more efficacy in patients on the high-dose medicine. At E, in Q3 21, we've initiated our first EU clinical sites for the premier study. And later this year, or just now, in fact, we announced, yesterday, we published our first phase 3 study in a peer-reviewed journal, and we're excited for all of you to see those results. In an ongoing basis, starting at G through J, we expect in Q2 of next year additional top-line data from our interim analysis of our extension study, both safety and efficacy, of course. And in Q2 22, we'll complete enrollment of the premier study. We will have top-line data from the pivotal study in the animal study in Q1 of 23. And then finally, as I've mentioned, in approximately September 23, we expect to have top-line data from the phase 3 premier study of 3003 in Charcot-Marie-Tooth. So I want to thank you for your attention today. We look forward to updating you in an ongoing basis about our advances in Charcot-Marie-Tooth 1A. We thank you for your attention and look forward to addressing any questions and concerns you have. We really believe that 3003 is an effective and safe, well-tolerated medicine for the treatment of this disease, and we really hope to play an instrumental role in helping patients, their families, and caregivers ameliorate many of the terrible declines of Charcot-Marie-Tooth using our new medicine. So again, thank you, and look forward to further discussions.